So it's not national standard of care to just screen every person who's coming in for treatment for fentanyl. And then if you did screen or found out somebody has fentanyl, well, what do you do about it? There's no national evidence-based consensus guidelines of what to do differently to treat fentanyl. But the truth is, it is a different approach. So at Symetria, we're trying to help develop the guidelines by doing a national initiative in terms of collecting data of how many people are having fentanyl in their system. We now screen every person who's admitted into our program for fentanyl, and if it shows that it's in their system, it could be tricky because of how that pharmacology is. Sometimes you actually have to delay starting buprenorphine to avoid precipitating a withdrawal syndrome. So we actually know if we identify fentanyl, that if we're using buprenorphine to kind of hold off a little longer, try to educate about why we're doing that, it leads to better outcomes. We're seeing data showing that you might need a higher dose of buprenorphine. And overall, a lot of patients, because of how strong fentanyl is and potent it is, buprenorphine sometimes doesn't have enough activation at the receptor, and they actually do better with the more traditional medicine of methadone. If fentanyl is one of their primary opiates of choice, then we've noticed that methadone can actually provide better relief of symptoms. And we give a little more intensity of services when we identify fentanyl as a drug of choice.